Hi everyone, this is Dr. Sapchinsky, and this presentation is on obsessive-compulsive disorder and other related disorders. Those other related disorders are body dysmorphic disorder, or BDD, and hoarding disorder. I have provided some short videos for each topic to help explain the epidemiology, symptoms, and management. And I want to give you a warning that if you find yourself triggered by any of the videos, please turn them off. Anxiety disorders are the most common psychosocial disorders in the United States and in primary care. Obsessive-compulsive disorder, or OCD, is the fourth most common disorder and a common cause of disability or loss of functionality. Remember, when we talk about disorders, we're talking about the fact that life has become unmanageable because of what's happening, because of the symptoms of the disorder. Now, this makes more sense when we examine the characteristics of OCD. OCD is characterized by unwanted, intrusive, repetitive thoughts which become obsessions. These thoughts are sometimes accompanied by actions which become compulsions. An obsession is a thought, an urge, or an image. You cannot get rid of it. It keeps coming back. A compulsion is a behavior that an individual feels like they have to do in order to relieve the obsession. It sounds a little like anxiety, but OCD is diagnostically separated in the DSM-5-TR, which is why it has its own chapter. OCD is grouped with body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, excoriation disorder, which is skin picking. Hoarding and body dysmorphic disorder were once considered forms of obsessive-compulsive disorder, but they now have their own diagnostic criteria. The emergence of OCD symptoms commonly occurs in adolescence, and it may be associated with a sense of shame or distress. Shame comes whether from the intrusive thoughts or the repetitive behaviors that this may keep people from seeking help. There are other psychiatric disorders such as anxiety disorder, mood disorder, but mostly major depression are present with OCD. We don't know the exact cause, but OCD does have an inherited pattern. Patients with OCD may present with symptoms of depression or anxiety because of their level of distress or inability to function, rather than stating, "I have symptoms of OCD." The primary care provider, the FNP, needs to have a high degree of suspicion for OCD. Patients often have good insight into their symptoms, and they can describe them when asked. Sometimes, however, they do have poor insight and maybe delusions or a fixed level of symptom intensity, like they're stuck at a certain point and they just can't feel better. Common obsessions include anger, contamination, order, religious, doubts, and sexual imagery. Compulsive behaviors include checking, cleaning, hoarding, mental acts such as counting, ordering, reassurance seeking, and other repetitive actions. It's important to determine the frequency, intensity, duration, and severity of symptoms, as well as the effects of the symptoms on a patient's level of functioning. Ask about triggers, relieving factors, and even avoidance of situations or things. Sometimes avoidance feels like a better idea to the patient than facing one's fears. Screening tools are helpful in identifying behaviors. They're also helpful in tracking progress of management plans. The Yale-Brown Obsessive-Compulsive Scale, or YBOC, has 10 questions about symptoms, which the patient scores from 0 to 4. 0 is none, and 4 is greater than 8 hours a day, or nearly constant symptoms. For scoring, 0 to 7 indicates subclinical symptoms. 8 to 15 mild, 16 to 23 moderate, 24 to 31 severe, and so forth. A children's YBOC is also available. On the list of differentials, there is a syndrome called PANDAS. PANDAS is short for Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcus. It is a group of symptoms or syndrome thought to affect certain children who have had strep infections. Group A beta hemolytic strep triggers production of autoimmune antibodies against strep. These antibodies may cross-react with the basal ganglia to cause symptoms. Symptoms or behaviors include tics, obsessive-compulsive behaviors, and mood changes such as lability. The symptoms suddenly appear after a strep infection, and they are described as overnight and out of the blue. Children ages 3 to puberty seem to be affected. An exact link has not been established yet, and it is still listed as a rare complication of strep infection. Essentially, it's a diagnosis of exclusion, but it's something to put on your differential list for pediatrics. Other differentials are body dysmorphia, excoriation, hoarding, trichotillomania, major depressive disorder, generalized anxiety disorder, and obsessive-compulsive personality disorder, autism spectrum disorder, and tics. Management of OCD begins with education of the patient, family, or caregivers about the disorder progression and treatment options. A strong therapeutic alliance in building trust is crucial for ongoing care. Increased risk of comorbidities such as anxiety and depression mean that the risk for suicide must be addressed. SSRIs are the first-line drugs for treating OCD in children and adults. They are typically prescribed at higher doses than for major depressive disorder and anxiety, and for longer periods of time, at least 12 weeks. Remember that not all SSRIs are approved for children, and that SSRIs carry a black box warning for possible increase in suicidal ideation. The tricyclic antidepressants are the second-line drugs. Non-pharmacological treatment includes CBT and exposure and response prevention, or ERP. ERP is designed to gradually reduce the anxiety that feeds obsessions and compulsions. One way in which this is thought to happen is through a process called habituation. This is where people become less physiologically aroused by triggering stimuli or obsessions after being repeatedly and safely exposed to them. You can think of it as desensitization. It can be used for OCD, anxiety, phobias, and eating disorders. Individuals are directly exposed to the stimuli that causes the fear, distress, or obsessive thought or compulsive behaviors, and they learn therapeutic techniques to prevent the maladaptive response, which is the compulsion. They get used to the trigger and they do not give in to the compulsion. Keep in mind that the compulsion was supposed to relieve the anxiety of the obsession, but it didn't. This slide is from the mood disorder deck, and the serotonin reuptake inhibitors are used as the first line for treating OCD. They are typically done at higher rates than for anxiety and major depression. Titrating should be done over 8 to 12 weeks before augmenting or adding a med or changing a medication. The typical starting dose for anxiety and depression is 50 milligrams a day, sometimes 25, but for OCD we start at 50 milligrams and we increase every week up to a max of 200 milligrams per day. It may take 1 to 2 weeks for initial effects to be felt and up to 12 weeks for significant relief. Obsessive-compulsive disorder can be refractory. That means resistant to treatment. You might have to use a higher dose or add other medications to help with symptoms. In these cases, referral to psychiatric mental health providers is recommended. Also, it's recommended that pediatric patients and more complicated cases of patients that maybe have many disorders are sent to psychiatric mental health professionals. Body dysmorphic disorder, or BDD, is a preoccupation with perceived physical defects or flaws. I'm ugly. I'm too fat. My eyes are not the right shape, etc. This develops mostly in adolescence, but it really can occur at any age. People with BDD often exhibit excessive repetitive behaviors: checking, fixing, concealing, reassurance, grooming. It takes hours and hours during the day to do all this stuff to make themselves look and feel better. The clinical presentation, they often come in depressed, anxious, sad, with poor self-esteem, and they're often ashamed of themselves and their bodies. They may request referrals for dermatology or plastic surgeons or orthodontists. I saw an episode of Botched recently, which is a show about a couple of plastic surgeons who repair botched cosmetic surgery. And in one episode, a young man of 20-something interviewed the surgeons because he wanted a specific type of cosmetic surgery. At this point, he had had over 25 procedures, including muscle augmentation in his thighs and his abdomen, and he wanted the surgeons to do something with his shoulders. And the surgeon said, "No, that is not healthy." So just know there's a lot of body dysmorphia out there driven by social media, advertising, and so forth. There's a high rate of suicidality and suicide in people that have body dysmorphic disorder. These individuals often lack insight into the problem. It's important to refer them to psychiatry when possible. For management, there are no FDA-approved medications, but as with OCD, high-dose SSRIs and BDD-focused CBT are recommended. Hoarding disorder was separated from OCD as a separate diagnosis. Hoarding is the persistent need to save items, difficulty parting with possessions or discarding things. The clinical presentation may come from a relative or a caregiver. There may be a cluttered home. They may collect things or animals, and when they collect animals, they don't necessarily take care of them. They may collect them in a room. There is risk for harm from clutter, such as falls or electrical hazards, fire hazards. And they have reasons for keeping things, such as there may be future value, or they like it, it's pretty. Sentimental value, my mother gave that to me. They may feel responsible for the item. That's my grandfather's violin. Or avoid being wasteful, or fear of losing some important piece of information. Probably all of us know somebody that has trouble getting rid of things. But when it comes to hoarding, picture a room in which you cannot see from one side to the other because of the amount of stuff that's there. Differentials for hoarding include other physical or psychiatric conditions. Dementia also comes to mind. The diagnosis is made when the behavior significantly impairs functioning. Remember that these folks that lack insight into the problem, they really don't know that it's a problem. Assessment scales are helpful in determining hoarding behavior. Oftentimes, the people have delusional beliefs about what they're hoarding. So we've gone from a collecting of things into delusional beliefs and into the disorder part, which means that life is becoming unmanageable. The management for this is cognitive behavioral therapy for hoarding. That includes weekly meetings, home visits, and education. And also, it has to do with stopping the collecting behavior and then moving forward to clearing out some of the items. This takes a long time. There's no quick fix to this. This is an example of the hoarding assessment tool that can assist with diagnosis. And you can see that, again, there's a 0 to 8 scale that a person selects, where 0 is not at all difficult to extremely difficult.